I'm Dr. Edward Nelson Friend with the Department of Orthopedics, Division of Joint Replacement Surgery, and today I'm going to be talking about patients that have arthritic hips and arthritic knees. The patient with an arthritic hip typically presents complaining of pain. Classically, the pain is located in the groin, which is where the hip joint actually is. Occasionally, they will also have pain in the lateral thigh or in the trochanteric region, as well as in the buttock. On rare instances, patients will actually only have pain in the knee, as hip pain can refer to the knee as well. It is important to ask the patients specifically what kind of limitations they're having on their activities of daily living, specifically looking at their ability to walk and how far they can walk, as well as performing their typical activities of daily living, including going up and down stairs and donning and doffing their shoes and socks. The first thing I will do when examining the hip is checking for motion in all the planes, including flexion, extension, rotation, and abduction. In assessing flexion of the hip, because the lordosis of the spine will flatten out at the extreme of flexion, I will slide my hand underneath the patient's back, behind the lumbar area, and in this way I can tell when his spine starts to compensate. I will then have the patient flex the knee and the hip. I'll bring the hip all the way up until I start to feel the spine move, and then that will be the maximum amount of their allowable extension. Typically that is approximately 135 degrees. You can then have the patient bring the hip down, bringing the other hip up, and flexing this as far as it will go to actually flatten out the lumbar lordosis. We can then check if there's any flexion contracture in the other side. If we bring the hip up and tilt the pelvis as well, the hip typically should be able to stay flat with the table. Somebody that has a hip flexion contracture, this will rise up in the air off the table, typically flexing at the knee. Motion that I would test would be rotation of the hip, and this can be done both in the flexed and extended position, and will actually change a little bit, especially with an arthritic hip. And I will have the patient actually keep the hip extended. I will place my hand over the patella and over the knee area, and I will just rotate the hip out. And you can actually use the foot as well as a bit of a goniometer to check the amount of external rotation, typically around 45 degrees, and the amount of internal rotation, typically around 25 degrees or so. Then with the arthritic hip in particular, as you flex the hip up, patients with hip arthritis will tend to externally rotate. They will lose their internal rotation and extension, which is why it is important to check the rotation both in extension and in flexion. Then finally, you can assess abduction and adduction of the hip. Again, when I do this, I want to put my hand on the pelvis to stabilize the pelvis to correct any compensatory motions in the spine, and bring the hip out as far as it will come. Typically in a normal hip that is approximately 45 degrees. Back to neutral, and then across the other hip in adduction, and that is typically approximately 35 degrees. Assessing tenderness about the hip is somewhat difficult because the hip, again, is such a deep structure, and it is very difficult to palpate the hip and put pressure on the hip. However, there are some areas around the hip that typically will be tender in other situations, such as trochanteric bursitis. The greater trochanter is the most prominent bony structure on the proximal aspect of the thigh, and applying pressure there in patients that have bursitis can be quite painful for them. And also there are the iliac wing as well as the iliac spines. The anterior superior iliac spines here in particular can also be painful. In assessing trochanteric bursitis, it is typically caused by tightness of the iliotibial band, which crosses the greater trochanter, and I will assess the tightness of that as well. And to do that, I will have the patient abduct the hip, extend the hip, and then flex the knee. And then, if the iliotibial band is tight, as you let the leg come back down to neutral and beyond, the leg will actually become quite springy and will not come all the way down to neutral. If they have a normal iliotibial band, it will come all the way down to the other leg, and if it is tight, it will not. I will also assess this, what is called an active straight leg raise on a patient. Typically, the arthritic patient has tenderness or pain in the groin region. Occasionally, you'll have discomfort in the lateral thigh or buttock region as well. Having the patient do an active straight leg raise, where they raise the leg under their own power, will reproduce their symptoms with an arthritic hip. So can you please raise your leg up in the air, have them do that to approximately 30 degrees or so, and if that reproduces their symptoms, then that is a very sensitive test for arthritis of the hip. And finally, I will assess the leg length of the patient, and there are two ways to do this. The first is a bit of a dirty way, but I will have the patient lying supine, and I will grab their ankles and place my thumbs on their medial malleoli, and then see if they are in the same plane. If they are, they do not have a leg length discrepancy. If they are not, then they do. A way to do this more specifically would be to check leg lengths based on bony landmarks, and typically that is done from the anterior superior iliac spine to the medial malleolus. So in assessing the leg length using a tape measure, I could palpate the patient's anterior superior iliac spine in the pelvis and the medial malleolus in the ankle. You can then place our tape measure on the ASIS and then measure the distance to the medial malleolus. You do that on one leg, and then you can do that on the other leg, being careful to use the same landmarks. And that will tell you specifically what each leg length measures.